I'm going to start. I'm going to introduce Dr. Toni Mitovski. Today, it's a pleasure to have him actually from the Ministry of Health. He has got a PhD and Master in Physics from Dalhousie University. And he's done a postdoctoral fellowship from University of California, San Diego, at the Environment and Climate Change in Canada. And he's worked for a simulation of the cloud processes in the American and Canadian climate model. During the time at the Environment and Climate Change Canada, he also worked on implementing novel model algorithm for data analysis and forecasting. And some of this algorithm include the random forest, neural network, and sequential models. So Dr. Mitovski worked as an economist and researcher at the Ministry of Health in Victoria, BC. And so he's another one of the physicists who has changed to the health, which is always delightful to see. But they bring all this expertise and knowledge and technical ability into health. So I'm delighted to have him to give us a talk on predicting 30 days hospital readmission for patients diagnosed with MHSU conditions using logistic regression and machine learning approach. Thank you very much, Toni. Floor is yours.
Excellent. Thank you for the introduction, Abdul. So I appreciate this opportunity and looking forward to present this project. And like you mentioned, the title MHSU means mental health or substance use condition. So, and I'm using a few algorithms. One was logistic regression and few machine learning algorithms. But all these algorithms that I'm using in this study, they are classification algorithms with imbalanced data. And they can be applied to other problems with the same imbalanced data sets. In this case, that means that that clients that were discharged from hospital and they were not readmitted within the next 30 days, they contributed to 87% of all cases. So this class, it's known as major class, and I added this orange circle to represent this major class. So on the other hand, the clients that were discharged and then readmitted in the next 30 days, they only contributed to 13% of all cases. And then this will be represented, and it's also called this class minor, and it's represented with this blue circle. Can you see my mouse when I move around?
Yes. Yeah, we do.
Yeah, okay, so I know that you can see stuff. So, and there's a blue circle, and this classification model that I will be presenting today, it was developed to predict the minor class, the blue circle in that case. I would like also to acknowledge that I'm grateful to live and work from the traditional territories of the Saanich people. I live in North Saanich, BC. And the session summary that I will be presenting today has 4 sections. So in section 1, I present information about the definition of hospital readmission and the healthcare data sets that I'm using. Then section 2, I'm presenting some basics about machine learning algorithms and validation tools. In section 3, I will be comparing the model's performance and present the most important factors that lead to increased probability of hospital readmission. In the last section only shows some limitation of this model and some plans. So if you have any question, you can interrupt me anytime. I'm very happy to answer any question as we go along this presentation. So how I got inspired was according to CIHI, and that stands for Canadian Institute for Health Information. and also an article published in Vancouver Sun in 2018. Based on all these, British Columbia had the second highest hospital readmission rate in Canada. And this time series here on the left side, they show the annual readmission rate for clients diagnosed with mental health or substance use condition, and this is based on CHI. Then you can see for this fiscal 2018-2019 here, British Columbia's readmission rate for clients diagnosed with mental health or substance use condition was 13.7%. This is in blue. And it was higher than the Canadian average of 12.9. And this figure on the right side here, it shows that these are readmission rates for the same fiscal year, but separated by different categories. So for example, the 30-day readmission for all clients, it's 10% in BC, and it's higher than the Canadian of 9.4%. So comparing now the readmission rates for mental health and substance use clients, so they were more likely to be readmitted within 30 days. And I also have computed the BC rates for the latest fiscal year of 2020-21, and they are estimated to be around 14.6%, and they are the highest comparing to the last 5-10 years. So these readmission rates are increasing. So the business problem for this was that these unscheduled hospital readmissions are very difficult, not just for the clients, but also for their families. And they are very costly to the healthcare system. So on average, and this is all based on CHI, these readmissions cost around $10,000 per episode, and they costed more than 1.8 billion in Canada only in 2017. And this went to 2.1 billion in 2018. So it is also estimated that half of these readmissions preventable. For that reason, we need some analysis and predictive tools to reduce the number of hospital readmissions through targeted interventions, and also improve the quality of the healthcare system, lower the healthcare cost, and increase the client satisfaction. There are some previous studies, but unfortunately, since most interventions are very costly, they involve several components and multiple healthcare practitioners. Some healthcare teams are now turning to using predictive models in order to identify these clients at high risk of readmission, and then focus their resources for intensive readmission prevention strategies on only these high risk patients. So in the recent 5 years about that, I've seen an increase in these predictive models, which use various algorithms and large data sets to generate these readmission risk scores for individual clients. But we still, it's not clear whether these interventions are more effective when they are targeted at high risk than at low risk clients. Also, new machine learning algorithms have been used to identify these high risk clients, high risk for readmission, but these algorithms, and also there are studies that show that these algorithms had higher predictive power comparing to the previous logistic regression models. So the objective of this is to integrate as much as possible healthcare datasets and apply various machine learning algorithms to predict the risk of readmission for BC. And then compare this performance of these algorithms with the performance of the previously used models, and identify the most important predictive factors that lead to an increasing the risk of readmission. And finally, to implement this model into a real hospital settings for early identification and risk assessment of clients with the potential for early planning and transitional care intervention. So that's the objective. And how I generated this flowchart at the beginning. The following flowchart shows this model development process. And the first step in this model, it's the get data step on the upper left. In this step involves extracting data, hospital data for clients that were admitted in hospitals, but only with mental health or substance use diagnosis. Then categorizing these visits if in readmissions or admissions. So admission will be not readmission. Then linking clients to other data sets, extracting data from these other data sets. And it was a lot data transformation because lots of these variables are alphabetic or alphanumerical variables, and they have to be converted to numerical. Then feature engineering, which means that I was creating new features from the existing features and stuff like that. So more about this get data step in the next few slides. And the other steps on this flowchart will be also explained in more details as we go along this presentation. But briefly, what's happening here is that after data was collected, then it was split into two train and test data sets. And the upper one, the train, was used for training model, and this test set was used for validating the models. So episodes of care and unscheduled readmission. So I used the ICD-10, which stands for International Classification of Diseases Diagnostic Codes, to identify client at hospital discharge if the client is diagnosed with primary diagnosis of mental health or substance use condition. So a readmission then was identified as the first admission to any hospital in BC within 30 days following discharge from particular hospital. So I also excluded records with scheduled readmissions because they were scheduled and they were just excluded from the analysis. And also to avoid transfers as two separate hospitalization. That's why I used episode of care instead hospital record, and to define discharges and admission dates and times. And the lower table shows that between April 1st, 2015 and March 31st, 2020, clients, this is for clients 15 years or older, diagnosed with any of these mental health or substance use condition, accounted for over 162,000 episodes. And 22,000, over 22,000 were classified as readmission and giving you an average readmission rate of 13.7%. So based on client, so we use client labels here, and these clients label a unique client number, and they usually stand for PHNs, like healthcare numbers. The episodes after discharge from hospital were linked, and additional information was extracted from other data sets. And I used information from 5 data sets. So on the lower left, you can see a discharge abstract database, and this includes administrative, clinical, and demographic information for on hospital discharges. So they come from the hospitals. Then it's NACRS, that stands for National ambulatory care reporting system, and this mostly comes from emergency departments. Then MSP, medical service plan, healthcare insurance plan for medically required services. Then it's PharmaNet down there. This is the province-wide network of that links all BC pharmacies into one system. And the last one is the mental health and substance use minimum reporting requirements, which provides information about clients, what type of services are using, and also sometimes you can get the diagnostic codes from there. So 5 data sets, lots of information here. And this table here, it shows that the old variables, at the beginning, I started with 80 variables. I came to 35. And it shows all variables and corresponding data sets used in the study. And they are ordered based on their relative importance in making decisions. And this relative importance was computed during a training step in the machine learning model. And so you can see, in addition to the variables that were available at hospital discharge, I also computed and included additional variables, and these variables are marked with yes in the column computed. So from this table, you can see that these engineered variables, computed one, they were among the most important fields used to predict whether client will be readmitted or not. And like I said, we used 35 here. So the flowchart now, it goes from get data. While data was collected and transformed, then, as I mentioned, was split into training set and like test set. And this training set included 80% of the data. This was used for, because this is classification model, it was used, all these models here are classification. It was used to train these models, and this 20% of the trained data, like test data, was used to validate the models. And again, because it's discrete, here we are using confusion matrix. The split was random split, decided randomly what will be 80% for the training and 20% for the validation. Okay, about the model something. So this LACE, this is the most frequently used model for hospital readmission. And it's usually called LaceCore Card. So the LaceCore Card was developed using logistic regression with records from Ontario. And I believe was developed in the 1990s. And it's frequently used model to predict the risk of 30-day hospital readmission. The name comes from these 4 categories in the table to the right. So L stands for length of stay. Then A, it's acuity of admission. And then C, it's comorbidity of the client. And E, it's the number of emergency department visits in the previous year prior admission. The LaceCore is calculated by summing all these points from all these 4 categories and ranges from 0 to 19 with a high likelihood of readmission for higher score. So 19 will be the highest likelihood. But it has been shown that the LACE performance, it varies among studies. So the more you read different publications, you can see the LACE has different precision or accuracy. So and I believe this is due likely because due to the difference in data cohorts used and the methodologies used for model validations. So another classification algorithms that I've used, logistic regression algorithm, and this is another frequently used model for predicting the risk of hospital readmission. In general, this logistic regression algorithm is shown with this function here on the top. It's an algorithm that fits a linear function between one binary variable, dependent variable, and one or more independent variables like this axis. And so this logistic regression model and the LaceCore Card were used as baseline models, and their performance then was compared with the performance of the decision tree and neural network algorithms. But decision trees, there are few algorithms, so you can use random forests or gradient boosting. They used an ensemble of decision trees to go from one observations in about an item. So this is represented usually in the branches. I have this cartoon on the left. To conclusion about the item's target value, and this will be represented in the leaves of this algorithm. So the cartoon on the left shows an example of one decision tree. So usually the best attribute of the data set will be placed at the root of this tree. And then at the nodes, we make decisions, and then we follow the next branch to the next node or decisions until we reach the leaf node with the final decision. There is one example here on in the middle. I found this online, so it's like to accept a job offer, then the salary is the most important attribute. It's placed at the beginning of the tree. And then if the salary is higher than some threshold, then we follow the left branch and then jump to the next node or decision. And then we go so on until we come to the final decision. So random forests use an ensemble of this decision tree, can be 10, 50, hundreds, and each tree is trained independently using a random subset of the data. And this then randomness helps to make the model more robust than a single decision tree and less likely to overfit the trained data. So overfit means you kind of try to fit the model to the trained data, but has no any predictive power for the like test data. Then gradient boosting algorithm, it's very similar to this random forest, but the difference is then in the way these trees are built, especially the sampling method, and the way the results then are combined. For example, in this gradient boosting, the algorithm builds one tree at a time, and then each new tree then helps to correct the error from the previous tree, and it's so on. It can be also have 50, 100 trees, and so on. On the upper right, you can see a neural network cartoon, and it's so neural network calls. The name comes from these neurons because they try to replicate the neurons of the brain, and these neurons cannot operate separately without other neurons. They're all connected in these networks. Usually they are grouped in layers and process data in each layer and pass them forward to the next layer. So then the last layer on the right will be the blue one. Then it's making the decision because it's classification algorithms. There are like 2 yes or no, or 1 or 2 yes or no answers. So these networks, they have at least 3 layers. One is on the left input, where you input the data. Then it's called hidden layer in the middle, the red, and in the output layer. And without this hidden layer here, this network becomes a regression algorithms. It can be logistic or just regression. So neural networks can have more than 1 hidden layer, and the more they have, they call them deep learning algorithms. So it can be 2 or 3 more. And it's very difficult to run them on just simple computers. So gradient boosting and neural networks they're very common in the machine learning community, but not very often used in this for hospital readmission models or some other models in the hospital setting. Both algorithms, as I said, can be used for regression or classification. But in this study, I used all these algorithms to predict the risk of readmission. So they're for the classification problem. And their performance then was compared to the performance of the LACE model and logistic regression models. I will not present all these algorithms today, but I will present only the results from the light gradient boosting model because this was the best performing algorithm for these data sets. Again, this flow chart, then the final, and this is one of the most important also step, is the model validation. It's the lower right. And without this proper validation, the model may not perform as expected. And then when used to predict the risk of readmission for new population, that you may get something like completely different. That's why choosing the right metrics is very critical. And for these classification algorithms, I use the confusion matrix for the evaluation in case wasn't classification or regression, you would go with root mean square error, something similar. So this is the confusion matrix. So most of these evaluation metrics come directly computed from this matrix. And you can see it on this slide. From this matrix, because my goal is to predict whether client will be readmitted or not, the readmissions will be labeled as positive class, while no readmissions will be labeled as negative class. So there are four outcomes now. You can see them here in white. If the model predicts that client will be readmitted and that prediction is correct, then this is labeled as true readmission or true positive. So this is in the upper left. If the predicted readmission is incorrect, then this will be labeled as false positive. And then the other side, it's if the model predicts that client won't be readmitted, but that prediction is correct, then this will be labeled as true negative. And finally, if the model predicts that client will not be readmitted, and this is incorrect, then this will be labeled as false negative. Most of the studies, they used a variety of these evaluation metrics, but mostly they have used precision and accuracy. And I circle them here. That's the precision, that's the accuracy. From here, you can see the accuracy, it's calculated as the number of correct predictions. So this will include readmissions and not readmissions. And then it's normalized by the total number of predictions. And it can go from 0 to 1, with 1 as the best possible result. Precision, on the other hand, it's calculated as the number of correctly predicted readmissions. That's what we need. And then it's normalized by the number of predicted readmissions. And also can go from 0 to 1, with 1 as the best possible result. And there are a few other like sensitivities here, specificity, and they use a few others, but mostly accuracy and precision. So this is to visualize a bit the difference. So it makes sense to use accuracy for binary classification, but we have to be very cautious when using this accuracy for classification with imbalanced data set. For example, I have here 10 by 10 matrix. to visualize this accuracy and precision, and each of these 100 squares in the matrix, it represents one episode of care. And these 10 gray squares, they represent readmissions. So in this example, a client has about 10% chance to be readmitted here. On average, so if we, let's say, use random guess, we will predict one correct readmission. This is the dark green. And 9 incorrect readmission, that's light green. So that's a random guess. For that reason, the readmission rate of 10%, and if you use model without any knowledge, like random guess, will score 10% precision, but 82% accuracy. So if they will tell you it's 82% accurate, it doesn't mean anything. So for that reason, model with the ability to learn from the data that we provide will have to outperform this random guess, and will have to score precision higher than 10% or be at least 82% accurate. And there are some results here. So the number of predicted readmissions now, first we use LACE model. Using this LACE model will depend on whether the total LACE score is higher than a specified threshold value used to classify these clients that are at risk of readmission. I mentioned that LACE can be from 0 to 19. And for example, for LACE greater than or equal than to 10, and this is frequently used threshold, the number of predicted readmissions was about 30% higher than the number of actual readmissions, with an average precision of 22%. And this is for BC, but I've seen in other studies that, for instance, using health records in California, LACE scored about 20% precision, and in Australia and New Zealand was around 23, 24%. So it's about the same. And like I said, the performance of the LACE will depend on the data used for evaluation. It may substantially vary among different studies. This figure in the middle here, it shows the precision on the y-axis of the light gradient boosting model and logistic regression model as function of the ratio of the number of predicted readmissions to the number of actual readmissions. So for BC, you can see the solid red line and the black lines for the gradient boosting and logistic regression, and Vancouver General Hospital VGH, it's represented with the dashed red and black lines here. So for each model, this ratio, so it's on the x-axis, it's a bit difficult to understand, but this was adjusted using a discrimination threshold similar to the LACE score. And this threshold is a tunable parameter in all these models. And it shows the probability at which the readmission is positive class is chosen over the negative class on no readmissions. So if we choose this as higher discrimination threshold, that will result in a lower number of predicted readmissions. So we increase this threshold, we lower the number of predicted readmissions. And that's why that gives us a lower X values on this side. So for example, at X equals 100, the number of predicted readmissions was equal to the number of actual readmissions. At X equals 10 on the right side, the number of predicted readmission was only 10% of the actual readmissions. Okay, so the model performance can be improved by tuning this model, this threshold, and we can just predict subset of these readmissions. With other words, like I can say the model can be used to target clients with higher readmission rates. Some numbers here, like let's say X equals 100, the light gradient boosting scored highest precision was 37% for BC and 43 for Vancouver General Hospital. And it was then followed by logistic regression and LACE models. And you can see that if you compare this to a random guess model, then these all three models had the ability to learn from this data here. Also, let's say the precision of these models and light gradient boosting logistic regression increased with increasing the discrimination threshold. At X equals 10, the light gradient boosting correctly predicted 65% of these readmissions in BC and 75 in Vancouver General Hospital. Also, the performance of these models did not substantially change with increasing the data volume from, let's say, 5 to 10 years. This suggests that, that the 5 years data capture all important links between the independent variables and then readmissions here. Also added these matrices on the side to visualize this precision as function of the number of predicted cases. So for instance, on the left, this will correspond to X equals 100. Let's say we have 100 episodes from which 10 were readmissions, and then so the model was tuned to predict the same number of readmissions, right? That corresponds to 100. So only 4 of these readmissions were correct, and that results at 40% precision. On the right side, then you can see the model was tuned to predict only 4 out of 10 readmissions. So we increase this threshold, and that corresponds to X equal 40. Okay, so only 2 of these 4 readmissions were correct, and that gave you a 50% precision. So that's it somewhere around here. Also added blue line here in the middle figure that shows the performance of a simplified version of this light gradient boosting model. So remember, I used 35 variables for all other models, but for this simplified, I'm using 5 only. And in this simplified version, I use the 5 most important variables to train and then validate this model. And these variables, you can see them in the table at the top. And so even though this performance of this simplified version, it's slightly lower, then this version can be very easy to apply now in a hospital setting. It's very easy to get these 5 data and input them and get the readmission, risk of readmission. Okay, so this figure here, it shows the distribution of the number of admissions. It's light brown or orange color, and the readmissions in darker brown. And the distribution of the average readmission rate on the right side in blue. And this is per interval of each of the most important variables. So what you can see here is that the risk of readmission, it's higher. That's on your y-axis. It's higher for clients that have been previously readmitted. So that's the number of admissions between, for instance, 20 and 50 years old, had longer hospital stays in the past 12 months, and then spent less time in acute and rehab levels during the last hospital stay. What I also did is that I used this simplified version of the model. This can be saved and then implement in a hospital setting as a calculator, let's say. And the model can be easily updated for a particular hospital or health authority, and then can be implemented as tool to assist clinician in their decisions. Right? So in this, the simplified version of the model will calculate the risk of readmission. It's down here. based on the number of past readmissions. So I provided some examples here. And then client age, hospital stays in the past 12 months, days in acute rehab units. And then this like table will show what will be the risk of readmission in percentage. And then we can use this discrimination threshold of 50 or 60%, let's say, to classify if the client will be or not readmitted. So you can see a 58 in one case says yes, in one no. Depends on the threshold values. So this model also has some limitations because, for instance, although feature importance, it's very useful and provides insight regarding this relative importance of the variables. This feature importance won't tell us whether higher values of some variable correspond to higher readmission rates. That's more like what you can get from logistic regression, for instance. But some other tools can provide insight into this. And I show that, for instance, histograms or probability functions, you can use them to get the insight of this data. And also some data sets, for instance, MSP and PharmaNet that I used in this model for model development are not always available instantly at hospital discharge. But I showed that the model performance didn't substantially change when I used that data that was instantly available. And that was the simplified version of the model. And also during the model development, information that was available at hospital discharge was used without considering post-discharge factors. That included, let's say, family and social support, and then the use of primary community care programs, and etc. And how these factors may impact the probability of future readmission. So this can be included, this post-discharge information, and they will likely improve the predictive performance of the power. So that's another thing. And finally, I have conclusion here. I use data available from hospital discharge 5 datasets, machine learning algorithms. They were used to predict this unplanned hospital readmission to other hospitals within 30 days of discharge. And I only use for clients diagnosed with mental health or substance use condition. And then I just compare the machine learning algorithm performance with the performance of the previously used model. And this machine learning model scored highest discriminatory capacity in terms of precision. And also this model was used to identify the most important predictive factors associated with the risk of readmission. There is still some improvement for this model, but it can be still implemented for early identification and risk assessment of clients diagnosed with mental health, substance use, or any other condition, with the potential of early planning and transitional care intervention. And also targeted intervention could be developed and implemented to effectively monitor clients and reduce risk of readmission of clients for future admissions. So that was my presentation, and I would like to thank everyone that attended this presentation.
Thank